Inspiratory muscle training is mostly used to treat respiratory diseases like asthma and COPD, but is also used to enhance sports performance by improving respiratory muscle function. There are 3 common techniques used to train the respiratory muscles, the first being isocapnic hypopnea, which uses hyperventilation whilst maintaining steady levels of carbon dioxide in the blood. The device used has a bag attached to the end so that the individual is able to inspire the expelled carbon dioxide to maintain steady levels in the blood to prevent fainting and prolong the respiratory training. The recommended protocol for this technique is 20 to 30 minutes twice a day, 3 to 5 days a week for 4 weeks. A study by Fairbairn et al. Saw an increase of 11% in maximal sustainable ventilation, and in another study by Morgan et al., there was a 90% increase in ventilation endurance at 100% MVV using this technique. The second technique is flow-resistive loading, which creates a resistance that restricts the airflow rate. The protocol for this technique is 20 to 30 breaths, 2 times a day, 3 to 5 days a week. A study using this technique saw an improvement of 32% in inspiratory muscle endurance. Pressure threshold loading, this is the third technique, has been widely used in research as the intensity of the load can be controlled. The protocol for this technique is 30 maximal breaths twice a day with the load set at 50% of maximal inspiratory mouth pressure. A study by Williams et al. In 2002 saw an increase in inspiratory muscle endurance by 128%, with the intensity set at 60% of maximal inspiratory mouth pressure. Lantis et al. 2001 looked at the effects of inspiratory muscle training on rowing performance. The study used 14 female competitive rowers who were split into an experimental group and a placebo group. The study measured maximal inspiratory mouth pressure, perception of dyspnea, rowing performance and blood lactate. A submaximal incremental load test that comprised of 5 stages, each lasting 4 minutes, was used. Participants had to maintain a stroke frequency of 18 strokes per minute, and blood lactate was measured at baseline and after the end of each stage. Following this was a maximal performance test that was used in both groups, with participants performing a 6-minute all-out effort row. The inspiratory muscle training intervention used pressure threshold loading, with the resistance set at 50% of baseline maximal inspiratory mouth pressure for the experimental group, who had to do 30 breaths twice a day, and the placebo group had the resistance set at 10% of baseline maximal inspiratory pressure and had to do 60 breaths once a day. The results from this study revealed a significant difference from baseline maximal inspiratory mouth pressure in the inspiratory muscle training group, both at 4 and 11 weeks, and also saw a significant difference from baseline in performance in the inspiratory muscle training group at 4 and 11 weeks and the placebo group at 11 weeks. Perception of dyspnea significantly improved throughout training for the inspiratory muscle training group, but no change was seen in the 6-minute all-out test. The decrease seen in perception of dyspnea could be due to the inspiratory muscle training delaying the onset of metabolite accumulation in the inspiratory muscles, therefore delaying the metaboreflex. Witt et al. 2007 looked at the relationship between mean arterial pressure and heart rate on the onset of metaboreflex. The study used 16 young males and measured mouth pressure, systolic and diastolic blood pressure, maximal arterial pressure, heart rate, tidal volume, breathing frequency, and minute ventilation. Pre-training in the form of resistive breathing involved the experimental and sham group performing 8 minutes of normal breathing to get baseline measurements. Both groups then had to inspire against a resistive load at 60% maximal inspiratory mouth pressure. This exercise was terminated once a plateau in rise of maximal arterial pressure could be seen. The inspiratory muscle training saw both groups do 3 sets of 75 breaths with 5 minutes rest between sets, 6 days a week for 5 weeks. The experimental group had the resistance set at 50% of baseline maximal inspiratory mouth pressure and the sham group at 10%. The study found a significant difference in the experimental group's heart rate and maximal arterial pressure response, but no change was observed in the sham group. Like Witt, these results could be due to the inspiratory muscle training delaying the onset of metaboreflex. The resistance in the pre-training will have conditioned the inspiratory muscles to work against a high resistance, and looking at the study, the resistance in the inspiratory muscle training was 10% lower than the pre-training, so the study might have had a better outcome had the resistance been higher in the inspiratory muscle training. This study concludes with the theory that inspiratory muscle training has the potential to improve whole-body exercise performance, yet unlike other studies where participants are asked to cycle, the participants in this study perform the intervention without exercise. Therefore, the data surely cannot be compared to those that have included endurance exercise in their studies. Burgess et al. 2007 looked at increased fatigue resistance of respiratory muscles during exercise after inspiratory muscle training. The study used 21 males and measured vital capacity, forced expiratory volume in 1 minute, peak expiratory flow, maximal voluntary ventilation, oxygen consumption and CO2 production, blood lactate concentration, breathlessness, respiratory exertion and leg exertion. Both the experimental group and the sham group performed 20 sessions of 30-minute duration. Participants had 1 day of rest between 2 days of consecutive training. Sessions were done at home, with every 5th session done in the lab whilst being supervised. This study found no significant difference for post-training in either groups, but when analysing subjects separately, significant difference was found in the respiratory muscle training group for both twitch gastric pressure and twitch diaphragmatic pressure. The significant difference found in subjects could be due to muscle hypertrophy of the diaphragm, thus increasing strength and therefore improving fatigue resistance. This theory can be supported by results found in a study by Downey et al. 2007, which found a 10% increase in diaphragm hypertrophy as a result of respiratory muscle training. Whether inspiratory muscle training is effective or ineffective is inconclusive, with some studies reporting improvements and others showing little to no improvement. From research that I've seen, there is little or no evidence that the effects of inspiratory muscle training are long-term. The studies used in this presentation could have done a follow-up post-intervention to determine how long any improvements last. This asks the question of whether inspiratory muscle training is worth it if the duration of effects are unknown. I cannot recommend inspiratory muscle training for those looking to improve performance due to lack of consistency in results.